got a code brown. Welcome to Bedpan Banter. With me, Nurse Mike, the daddy of nursing. Can I get a bedpan over here?
All right, continue our conversation with Nurse Julie, the hospice nurse, New York Times bestseller. Welcome back to Bedpan Banter, the official podcast of Simple Nursing, where we discuss the human side of healthcare. Welcome back, Julie.
Thank you.
So for all of our nurses watching this, what is a lesson from your book, Nothing to Fear, that can help them provide better care even outside the hospice setting?
There's so many. I think to not be afraid to say the thing you're afraid to say, or like the elephant maybe in the room. Like, be the one person who says, like, let me tell you about what you can expect with your end of life journey.
Is that how you would start it?
I would always word it like that.
Should they ask a question like, do you want to know?
Yes.
Okay.
That's very good. Listen to him, not me. I guess, well, because I'm always coming from like a hospice nurse perspective already, right?
Yeah.
So we're like,
everyone knows they're dying.
They already know, right? But if they don't know, right, you can always say, like, do you want me to be a little candid with you about what I think is happening here, what I'm seeing? This is what, like, from my experience, that's what I always try to say. And also, if you're in a hospital setting, I would just like go rogue and just start telling all your patients, like, I think you're dying, right? But you can be the person who talks to the doctors.
Correct.
And says, hey, can we have a family meeting? I feel like the family doesn't fully get that this person might not make it. You know, they might not live. What do you think? Do you think we should start talking about that? Do you think in 9 times out of 10, if that is truly what's happening, they'll say, yeah, I think you're right.
Yeah. And this is mostly applies, I mean, it could apply to every department.
But also, I think, too, if you want to just talk about even not just being a human being, right? Because just really fully understanding and learning about death through my book or watching me online or whatever other way you want to learn about it, right? I think helps you get a little more comfortable with the idea of death anyway. And then you being more comfortable somehow helps everything else proceed, right? You're suddenly more comfortable, so you're talking about it with your family, your friends. It just happens to start, and just things will unfold for you, right?
Yeah,
I think,
flowing.
yeah, I think it's important that people really understand. I mean, if you're a nurse or a nursing student, to fully understand the biology of death, which is in this book.
This one.
Yes, was fascinating to me. And I know as a nursing student, I would have been like fascinated by it.
I'm fascinated right now because I'm like, geez.
There's like a biology to death, which I did not know that.
We need to animate this one and put it together. So speaking of the physiology of death, can you explain the rally phenomenon that happens near death?
Yes. So there are phenomena that happens at the end of life. So I talk a lot about like the science of end of life, the biology of it, right? And there's a whole chapter in my book, chapter 6, about the phenomena that happen at the end of life. And there are certain things that are, I mean, dare I say, like medical mysteries. We don't know why they happen, but they happen all the time, and they happen at end of life. And the one that happened the most is something called the rally or the surge of energy. Those are like the nicknames. The real name is called terminal lucidity.
Terminal lucidity.
Yes.
And this happens right before death or when?
Right before death. So
like minutes?
It depends. So the way it looks is someone looks like they're very, very sick, right? And like grandpa's going to die. Everyone comes into the room. He's going to die. And then suddenly grandpa has, or it doesn't have to be a grandpa. It can be anyone of any age dying. Has a burst of energy, hence the surge. They call it the surge or the rally. A burst of energy where suddenly they wake up, they're talking to you normal, their like personality comes back, they're like sassy or jokey. Sometimes they walk around.
No.
Yes. So, and it can be as dramatic as that or something subtle where they wake up and say like, I'm hungry, can I have my favorite cheeseburger or whatever, right? But the part that people need to know about is that they will die soon after. So it is not the rally if they don't die afterwards. So it's like some people can like be looking very sick and then get better, and then they prolong their life, right?
Yeah.
The rally is sick, burst of energy, die.
Okay.
So they die, I mean, maybe a couple days after.
A couple days? Oh, okay.
I mean, sometimes it's hours.
Okay, yeah.
Sometimes it's a day, a couple days, or at least they'll go back to where they were, right? So if they were like kind of in a coma, burst of energy, back into a coma, usually die a couple days later. And what happens is people are going to be listening to this and they're going to go, that happened to my And so that happened to like, you just don't know what that is, right? People just think they're getting better and then they die soon after. Like my grandma, so my grandma died at 91. I think I was in nursing school at the time. My mom didn't know what it was, but after she heard me talk about the rally on social media, she called me being like, "Oh my God, your grandma had the rally." I didn't know that's what it was, but yeah.
That's crazy that the science told us.
Yeah, I mean, we don't know the science to what it is,
But at least we know the trends.
yes,
That's
yes,
what I'm
yes,
saying. That's
yes,
amazing.
yes. And it happens in 1/3 of all patients, so like 1 in every 3. Mm-hmm.
We mainly focus our simple nursing videos on pathophysiology of like what surrounds death, like the death rattle, Stokes. Can you speak on those particular physiological processes?
Yes, so both of those things happen during the actively dying phase, which is the last phase of life. Almost everyone, if you're dying a natural death, meaning your body has gotten some time to slowly progress to this phase called the actively dying phase. And your body will start doing certain things, which I'll get to, like Stokes breathing, the death rattle, and it's very, very misunderstood. So I've had so many people write into me and say, my loved one had the most horrific death. It was so traumatizing to watch. They were gasping for air. They were suffocating on their own fluids. And I think to myself, one, I don't want to take away their experience and go, hey, no, that wasn't bad, right? I know if it feels very bad, it feels very scary. But what I think is, oh, they just experienced their loved one going through this very natural phase, but no one explained to them what's going on. So it looks like they're suffocating. It looks like they're drowning on their fluids. And really, it's just all physiological. So the actively dying phase is a part of life. And almost everyone looks the same. So they're going to look, they're not look, they're going to be unconscious. So fully unconscious, not waking up to tactile stimulation. Sometimes your eyes and mouth will be open because it takes muscles to close your eyes and to close your jaw. So sometimes they're high and open. Their eyes will be open, maybe, and not making eye contact. So people will think their loved one's like awake, but they're not. They are offline. Okay. Then, as you're getting closer and closer, as you and I know, and a lot of nursing students and nurses know, your blood chemistry starts changing, right? So your pH is off, your CO2 is up, your oxygen's down, all these things, and it's causing you, because of this metabolic change, to breathe differently.
That makes sense.
Yes. So you start breathing differently, but they are fully unconscious, right? So then you start having these changes in breathing. And one of the changes in breathing, it's called chain Stokes. And it's basically like rapid breath, long pause. And then people are looking at their loved one like, did they die here, right? And then because they're doing they think, oh God, they're suffocating. They can't breathe.
Yeah.
And then they go into agonal breathing. Agonal breathing is literally a reflex. They're probably not even getting air. They're probably actually...
It's like your last die.
Yes, your last. But people associate that because they don't know. It's no one's fault. That is just a reflex of the body, right? So all of these things are naturally happening. And we know they're not causing the person distress because of how they look. So they are fully they're relaxed. They're not flinching. They're not making this kind of face. They're not guarding when you touch them. Now, if they look like they're taking too much energy to breathe, we will give morphine and stuff. And usually we'll err on the side of making sure they're comfortable and making sure they get morphine. But I think the main thing is that I like to educate is that it's normal. This is not happening because something's wrong. This is happening because this is how the body dies.
No one tells us about this.
No one tells us.
Did
you know? I didn't know.
I didn't know that. I knew they do a great job with birth. And it's like,
Right.
here's Lokia. Oh, you can do this and this. And like, here's Petekia and the baby and yada, yada, yada. And Mongolian spot. Like, okay, these are all natural things. I'm like, okay. But no one tells us, like, here are the steps to die. Like,
yes, and what it's going to look like. And even in the ICU, it looks a little different because we give IV medication. They've been on a bunch of machines. They don't have this long, drawn-out thing. So even... people always think you need to be heavily medicated during that time. I'm okay with people being heavily medicated if they want, but our bodies are so magnificent that they are shut. That person is offline. They are not. And the reason why we know that is because, believe me, I have seen when patients are not offline, right? And they are uncomfortable with breathing. They will look Like, I can't breathe. They're looking at you like, I'm not
Like
okay
like
here.
choking.
Right? Yeah. It's almost like a baby. Like, you can tell when a baby is wet or fussy or teething, right? It's going to be crying a lot, restless, not sleeping well. It's exactly like a dying person.
Yeah.
Like, they will not just be laying there like they're asleep if they were uncomfortable.
Yeah, they can be fighting it for sure.
Yeah, they'll be fighting it.
Yeah.
So the last thing that people hear is the death rattle. It's such an awful name, but it gets that name because it's the last thing you hear before someone dies. So you hear this rattling noise. It's called terminal secretions. That's the real name.
Okay.
AKA the death rattle, because when you hear it, they're likely going to die soon. And all it is, so it's with every breath, you hear a little gurgling noise, okay? And a lot of people associate that with coming from their lungs. They're drowning on their fluids is what
That's where I get that.
Yeah.
Okay.
Now, I will say in the ICU, because we do fluid overload patients who can't handle the fluid, they do get really congested in their lungs and they can kind of sound like what we would call wet. That's not what's happening here because the person is not wet. They are super dry because our body dehydrates ourselves, PS, to make us die easier.
Prepare you for death, yes.
Yeah, hence why you don't want to give IV fluids to a dying patient.
Oh.
Another
little tip here.
Another little tip,
Mhm.
nurses, never give IV fluids to a dying patient.
A hospice dying patient.
A hospice dying patient. Well, because let's just, okay, now I'm getting off topic, but this is really important.
Let's get into it.
If someone is really dying, then their body is like, we're done. You can put all the IV fluids you want to in that body. It's not going to stay intravascular. And we already see this, ICU nurses, you pump them full of fluid and it seeps out. It starts third spacing.
Really?
Yes. And then we have to intubate them because it causes respiratory distress. And then we have to diurese them. That's all we did in the ICU. And again, like, we weren't doing anything really wrong. We were trying to keep them alive. But if a dying body is dying, that fluid is not going to stay intravascular and hydrate that person. It will not. It'll seep out, cause third spacing. Eventually, their heart can't handle it. Pump.
Are they conscious when this happens? Or
They can be conscious.
Wow.
Yeah, they can.
Have you
be
seen
conscious.
anyone like really want to live, but their body says they're gonna die?
I mean, I saw it in ICU a lot. I didn't see it in
yeah.
hospice because I really try to educate, being like, listen, even if you did this, you're gonna cause them more pain. So what I usually say when a family's like, we're dehydrating them, how can we be doing this? I say, like, what do you want for your loved one? And they say, for them to be comfortable, for like us to help them. And then I say, that's what I want to. And if you hydrate them, it's not going to do what you think.
They're drowned.
They're not going to perk up like you think. Sometimes they will if they're really not end of life. But I can usually tell just because I've been doing this for a while that, like, this isn't going to do anything.
All right, picture this. You're walking into clinicals or a shift and you already feel behind. The last thing you should be worrying about is your scrubs. That's why I personally shop at Uniform Advantage. It's not just scrubs, but it's the marketplace for healthcare professionals. You'll find top brands like Cherokee, Healing Hands, Skechers, and more. Plus, nursing shoes that don't destroy your feet. Trust me, you're going to be on your feet for 12 hours. Also, stethoscopes, which come in really handy and doctors love to take it. Jackets, keep you really warm for those very cold hospitals, and all the extras that you'll ever need. And what you'll love the most are the options. We all love options, right? So whether you're into joggers, classic fit, or something in between, Uniform Advantage has you covered with the latest styles. And it's all priced for nursing school budgets or your first new grad paycheck. So go ahead and check it out at uniformadvantage.com today. Use discount code SIMPLENURSING at checkout and upgrade your shift with 15% off your next order.
So the death rattle. The death rattle is, we are sitting here, right, and our body's creating moisture for our mouth because our mouth's being moist feels better than dry, right? And we unconsciously swallow our spit all day long. At the end of life, our body stops doing that. The brain's kind of offline. It's not really telling us to swallow spit, but our body is still like, hey, a moist mouth is a good mouth. It feels good to have a moist mouth. So it still creates the saliva, but our body is no longer telling us to swallow it. So this little bit of saliva collects in the back of the throat. And because the mouth is open, like I said, because it takes muscle to close your mouth, with each breath, that wet air going over even that little bit of saliva will make a gurgling noise, which makes people really uncomfortable. Not the person dying, but the people around them. They're going like, ugh. And in the hospital, what do? We suction. We always suction. But the suction actually creates more saliva because we're introducing something to the mouth to make it get even more moist, right? It's like a foreign object. So it's like the body will start producing more saliva. So yes, on hospice, we can order suction machines are portable if a family really wants it. But I always try to educate, like, it's just going to perpetuate this problem. There's medication we can give to dry up the secretions, but again, then your loved one has a dry mouth, right? So I think it's more about, there are things we can do about it, but it's more about normalizing it and that it's not bothering your loved one. How do you know? How do you know?
Yeah.
That's what everyone always says. You've never done it. How do you know? You've never died. And we know because we see when it actually does. You can tell when someone's bothered because they're not going to lay there normally. They're going to be agitated. They're going to be trying to cough it up all the time. Again, if your loved one looks like they're sleeping, but you're seeing all these changes and hearing that noise, as long as they look okay when you touch them, they don't like jerk away from you or anything.
Totally unconscious.
Yeah, then they're good. But no one knows that, so no one knows they're good. Hence the education.
Education is the key.
Yeah.
All right, let's move into some Q&As here from your followers. The question that we always get, I think every nurse always gets, is what is the craziest experience that you've had?
Oh man.
I know you've worked ICU and hospice.
I mean, I have so many. The one I've been telling a lot, which I didn't for a long time, because you mentioned earlier how you were spiritual, right? And as an ICU nurse, even as a hospice nurse, you're like always science-based and like none of this is really happening. But once I became a hospice nurse, there's so many crazy things that are unexplained that you can't deny it, right? You're like, what the heck is going on here? And one of the things that happened, I didn't know this was called this, but I now have learned that it's called a shared death experience.
A shared death?
A shared death
near-death experience.
Yes, not a near death, a shared death. I didn't know it was called this until I shared it once, then everyone told me about it. So one of my favorite patients, he came onto service. He was a young guy, pancreatic cancer.
Oh.
Didn't have a lot of friends or family, and he was young, and and there's a whole hospice team. There's not just the hospice nurse. There's a social worker, there's a CNA, there's volunteers, there's a chaplain, right? This guy really needed a lot of support. He was young, he didn't have friends and family, and he had a hoarding issue. So we walk into his house to admit him into hospice, into his home, right? And his house was not safe. It was like organized mess, but it was like enough to be like, oh, you can't be here, right? And like, we can't do it here either. This is not safe. And for whatever reason, because I mean, hoarding is a mental health issue, right? And normally people who are hoarders like have a hard time letting go of these things. But for whatever reason, this guy let us like call in distant cousins of his, and like within a weekend, they had like gutted his whole apartment.
Whoa.
When I came back the next week, it was like a whole new place. And he was like a whole new man.
Really?
Yes.
Huh.
And he was like, I get chills just thinking about it. And he was like, there's something about knowing I'm going to die that I was just like able to let it all go. Wow. And then he ended up living quite a long time for a pancreatic cancer patient. And pretty well too. Like he didn't have a bunch of issues. So like I was just sort of visiting there like as a nurse, obviously, but like there wasn't much to do. So him and I would just sit and talk about all types of things, his life, what he thought about death, if he was scared. And he became close with all of us. And by the end of his life, he was actively dying, which is when, fully unconscious, changes in breathing. I could tell he would die soon. We had a continuous care nurse in the home with him, which meant a 24-hour care nurse, making sure he was comfortable. And I, as the nurse manager or the case manager, would just go in and see him once a day, okay? So the last day I was there, I could tell this was going to be his last day. I could tell by how he was breathing, like, okay, he's probably going to die today. So I said to the nurse, like, make sure you text me when he dies. And I kind of said my goodbyes to him in my head. And I was like walking out of his apartment and like thinking fondly of him and not really feeling sad because I felt really good. Like we really helped him die well, and he had a really good last, 9 months or whatever it was he was on service. And nurses know, you got to keep moving, right? Like, so I'm in my car, like getting ready to go to my next patient. But I was like, no. And I stopped myself and I was like, looked at his apartment and thought of him again. And I was like, oh, I just love you so much. Like, thank you for being my patient, blah, blah, blah. All in my head. And suddenly, this is where it gets crazy. Like, I feel embarrassed, like even talking.
No, let's pull it out. Come on.
All of a sudden, I heard his voice in my head. Like, clear as day.
From the other side, kind of.
And he goes, oh my gosh, Julie. I know, I got chills just thinking about it. And it was like, oh my gosh, Julie, oh my gosh. And when I heard his voice, I kind of like had a vision of him. It's so hard to articulate, but it was like he was like soaring,
Going through the light,
right?
going
Like,
to the light, or like
and
soaring.
going like, oh my gosh, oh my gosh. And I'm smiling because that's how it felt. It felt like he was like, oh my gosh, Julie, oh my gosh.
It's happening.
Yeah, if I only would have known.
Yeah.
Those were his words. If I only would have known.
Oh.
And he didn't fully articulate, if I only would have known, I wouldn't have been so scared, you know?
More of a static joy.
It was like the feeling, if I only would have known how good this is,
Yeah.
like I wouldn't have been so scared. Because we had conversations about how he was scared and he didn't know what he believed and he didn't know what was going to happen. And he lived a life, this is where it always makes me want to cry. He lived a life that was so constricted and so small for so long because of his mental health issues. He didn't let people in. He didn't live this full life and he regretted it. And he felt so free in that moment. And I felt like he was showing me that and going, oh my gosh, I can't believe this. I can't believe this. This is actually, he just kept saying, if I only would have known, if I only would have known. That's what he kept saying in my head. Oh my gosh, Julie, if I only would have known. But the feeling was like this joy and freedom. And so much so that in my car simultaneously while this is all happening, I'm like weeping in my car, like weeping tears of joy, because of the feeling he was giving me, right? And it probably only lasted, I don't know, 30 seconds, maybe even shorter. I don't know. Like time totally was jacked up. I don't know how long it was.
He blacked out.
And then all of a sudden, boom, I'm kind of like back in my car. And that's what it felt like. I'm like back in reality. Yeah.
Bam.
And I was like, oh, like kind of like wiping my tears, like what the hell? And I got a text on my phone and I looked and the nurse inside said, so-and-so just died. And I was like, I know, because I think he just showed me. I think he just showed me what it was like to die. And I didn't say that to her because I'm a nurse and I don't, I'm like, I can't say this.
Did he visit anyone else or was it just you?
That's the thing. I didn't tell anyone. I didn't tell anyone for years. I didn't tell people I worked with. I didn't tell anyone.
Yeah.
I was too afraid.
Yeah, of course.
I was too afraid. So I didn't say a word to anyone. I didn't say a word to the nurse. I didn't inside. I didn't say anything to the social worker. I didn't say anything to anybody except for my best friend, Jenny.
Okay.
Because I knew she wouldn't think I was crazy. But I didn't tell anyone that for years until years later, I was on social media and people kept asking me why I wasn't afraid to die. And then there's many reasons why I'm not afraid to die, but that was one really big one.
Mm-hmm.
And I thought, oh, screw it. I'm just going to tell people.
Oh, yeah.
And then I did. And that's when everyone said, girl, that's a shared death experience. That's what it's called. A shared death. People kind of show you what it's like.
Gosh, this is like science kind of. I mean, like.
There's
a trend.
Yeah, there's a trend.
And if more and more people are saying this, side note, for example, there's something called near-death experience, and I started binge watching this on YouTube over the past year. There's over 1,000 cases. There's a really good book, and it's all just documenting near-death experiences.
Yeah.
Where people float above their body, they know what's going on in the operating room, then they go back into their body.
Yeah, I mean, I feel like I've already had a type of spiritual belief, and then the experiences I've had have just helped me kind of be like, oh yeah, okay, this all makes sense.
Yeah, it's really interesting.
Yeah. It's amazing.
Whether you call it spirituality, science, or whatnot, it's just observation, right? That's all we do as nurses, and we document.
Yep.
And so if you have thousands of people doing this or a shared death experience, and they already termed it, this is wild.
Yeah.
This is amazing.
It's wild. I always just, like my whole take is that like, I don't know why it's happening,
but it's happening.
But it's happening. And like, it's comforting, right? Whether even if it is just our brains making us feel comforted, it's not a wonderful thing.
Yeah.
How beautiful is that?
And I think it's weird that we've reached so far on the other side of the spectrum where before everything's evidence-based now, right?
Mm-hmm.
Before, like in medieval days, like to practice medicine was like witchcraft, just say, it's like, what are you doing? But now we've reached the opposite side of the spectrum where it's like, we've scienced the heck out of ourselves that we don't even want to realize a common trend that's happening. And we want to put our head in the sand and be like, nope, doesn't exist. I don't know.
Yeah.
It's like, dude, is this actually happening?
Yeah. Well, I mean, one of the major phenomena that happen at the end of life is visioning. 80% of people see dead people.
No, wait, I see dead people? Really?
Yes. Oh, I mean, it's like so common that we have to educate families about it.
Yeah.
Because if we don't, the families get scared because their loved one dying is saying they're talking to their dead dad,
Yeah.
and they get scared that that's happening. not the patient. The patient's not scared. The people watching it feel scared. It happens so much. It's hard for me to even like tell one story because it happens so often.
You need to write a second, like a whole
I know. I just might be.
another book, a little chicken soup for the soul, like little
Mm-hmm.
shared experiences.
Yeah.
Thank you so much for being on the show. Guys, Nothing to Fear, New York Times bestseller, and the practical journal that goes along with it. Where can our listeners and viewers find you?
So anywhere you get social media, YouTube, TikTok, Instagram, Facebook, at Hospice Nurse Julie.
I love it. Well, thanks guys so much again for watching Bedpan Banter. And as always, don't let the bedpans bite.